thank you. Awesome tools some of you have here. You know what doesn't appear too much in my biography is the fact that actually I worked as a part-time, I was in the morning doing the work of a doctor in the Institute for Lung Diseases in Bucharest, and in the afternoon I was a journalist for one of these glossy magazines looking at the scandals and people having affairs with other people and having the kids of other people. So, we had a camera, and we had a different tool to record all of this. I was doing interviews. So was a different type of work than today, but useful in understanding what people would like to know. So thank you very much for being here, and I want to thank our colleagues from the National Press Foundation for putting this every year, and for having an increased number every time of colleagues in the room. And you will hear about many things these days. And I'm here, as well as some others that will be here this afternoon as well and tomorrow, to speak about tuberculosis. And in TB, we are in a very, very big need of attention and of everything possible that can come from your work. Any single word that you can write about TB, being it good or bad. Even if you tweet today and say, there was this woman coming, I got nothing from what she wanted to say, even that will be helpful as far as you say tuberculosis in it. Or these people in TB are having problems in putting their heads together, go ahead. Bad news, make the news, isn't it? Or, you try to write, there will be a nice TB program launched in a country, I don't know how many will pick it up. If you go and say TB kills every hour 200 people in my country, then it will be really picked up. So we every time when we come to present in front of a group is like, what do you expect to happen? The least that can happen is that we have a group of 20 young people working with media that will be aware that we still have a problem with tuberculosis. And that you will be aware for yourself and your families and your kids and your neighbors that in spite of having this disease with us for 2,000 years, we are still having it and we are unable to get rid of it, to our shame. So that's the least that can happen. The awesome thing that can happen is that you go back and you write about this experience, but also you write about TB in your countries, and you try to understand what's happening and how it is addressed in each of them. We are at a moment in which, kind of a bit sad, we just saw the WHO report launched last week, and actually, I will tell you something very, it's sad. I didn't redo the slides of last year because nothing changed. So the figures didn't change. I can still speak on them from one year to each other, which is a very disappointing situation. But I started by saying that TB is a disease that is with us for thousands of years. Robert Koch, who discovered, who looked at the microscope, and he was the one who discovered Mycobacterium tuberculosis in 1869. If he will be with us here today, he will be extremely comfortable because things didn't change too much since then. He will not be like, oh my God. He might be surprised by the computers, but if we take him to a clinic, we still use the microscope, unfortunately, in most of the clinics to diagnose TB. The vaccine is as old as he is 100 years old, and doesn't even work. And then we have some new drugs that came in after 50 years of silence. So it's not that we are having some breakthrough and we have some of these great, point of care diagnosis, some short regimens for TB treatment. We are still at a stage that any of our ancestors will feel comfortable to speak about TB, and this is something that should worry us a lot, because TB is the disease that actually killed the most in the history of humanity, and you have here the numbers that actually were put up by the people from Nature. And you hear now, we had in the other room, we had Minister of Health of South Africa, Motsoaledi, who spoke about the craziness that, the entire story of Ebola created in his country, even where there is no case. And he compared the fact that there is 0 person that died in South Africa of Ebola. There is a threat. He has 60,000 people in South Africa only dying in a year of tuberculosis. which is 5,000 per month, only in South Africa. So it is very worrying, on the fact that in spite of having a disease that kills so much, it killed last year 1.5 million people, equal with HIV/AIDS. It's getting, and it's curable, and it's affordable to be cured. It's really a bit shameful for the humanity to be in a situation in which we still have to die because of TB. My name is Lucica Ditiu, and I'm in charge of the Stop TB Partnership, which is a global partnership engaged in trying to get all of us together to go at a point in which we will have no more TB killing people in the world. And we are doing a pretty lousy job because we still have TB killing people in the world. And you will see more why I think that we need to do something and to accelerate if we want to go somewhere rather than continue the same things in the same way. So this is just to give some examples of people that are, the number of people that are dying. But more important than this is this slide that some of you probably saw already, which is showing a decline in the mortality, in the incidence, and in the prevalence for TB. So, which is good, because it shows that the numbers are really going down. The problem that we have is that when we unpack these numbers, and we look over where is, I'll just go back to this just to reiterate the thing, where we are right now at the global level in terms of incidence, and where we should go if we want to get and terminate TB as a pandemic in the world, which is an average of 10 cases per 100,000. If we continue to decline at the current rhythm, so you see we are now at 125 per 100,000, right? The global target for 2035 is to go at the level of 10 per 100,000. So we don't speak about elimination. We still speak of having 10 people per 100,000 with TB. So it's not elimination. But if we continue decreasing at the same rate as we saw in the last 10 years, which is 2% per year, it will take us to reach that target, 180 years. So the reality with TB is that it takes so long, if we don't accelerate and start thinking in a different way, that it will become irrelevant, even our entire fight about this. This is the European region, just to show that it doesn't look much better, because the European region, it includes a lot of the Western European countries. They have a target of going to 10 per 100,000 by 2020. If they continue in the current rate, they will reach it in 2043. And that's just maintaining what we are doing right now. This is very interesting. This is the slide of last year, and it very well survives this year because these are the same numbers. In a nutshell, you don't need to, if you want to capture the attention of the big decision makers, and unless you really write a very scientific article, what you need to remember is that globally, we report 9 million new TB cases every year. That's what we estimate that there is in the world, 9 million. Countries are reporting to WHO their cases. When this is cumulated, it gives a total figure of 6 million. So this leaves us 3 million cases that are not found, not treated, and not reported every year. This was the same figure last year, the year before, the year before, the year before, and the year before, the year before. So basically, for the last 7 years in a row, countries are failing to detect 3 million of the 9 million new TB cases. And that's because a lot of the attention is devoted to, is happening for people like us. We are aware of our rights, we know where to go, we know how to access the services, we have our papers in order. The missing cases are those that are not like us, are those that are poor, that are migrants, or those that are having, for whatever reason, a reluctance in accessing the public health service. In TB, we have an approach which is called passive case finding, which means that we are passively waiting for the patients to come to us, which is good in certain environments in which, people are aware where to go. But when you speak of those that are, the most in need of these services, you need to make that extra step and extra effort to find them. I don't know if you. It's okay. There was the other one, the small one, the thin one that fell. I don't even know where. Okay, so, oh my God. So, I will go back to what is TB and what is MDR-TB. Maybe I can keep them.
Over here.
Yeah. TB is a disease. Did any of you wrote particularly or know anything about TB? Okay. So it's airborne. You know that there are 2 billion people infected with TB in the world. I am one of them. I imagine most of you here are as well infected, coming from some of the high burden countries. During our lifetime, and when our immune system is not coping anymore with that, some of us will develop TB for whatever reason. And then if we are not put on treatment, we are infecting others. The duration of treatment is 6 months. But if for whatever reason the treatment is not properly followed, the drugs are not of good quality, this crazy bug learned how to deal with our idiocy, and it moves to become resistant. And then MDR-TB is the flower of the resistance. It's a very difficult disease to diagnose. It's a very difficult disease to treat. Just to give you an example of the size, the treatment, the drugs only for the normal TB are around $40 for 6 months per person. The MDR-TB, the average that is used right now is $4,000, just the drugs. It can go so crazy that in US, to deal with an MDR-TB patient, it can cost up to $300,000 because this includes, of course, the isolation in a negative pressure room and all the package around that. So having MDR-TB has a huge impact, not only on the fact that it's costly. It has a huge impact on the individuals because it's a horrible treatment. It gives a lot of side effects, and sometimes you have to choose between having your lungs, all destroyed by tuberculosis, or agreeing because of the treatment to become deaf, because some of the drugs that are taken produce deafness. And we have some people here at the Union Conference that went personally to this situation and had to choose. I would like to continue with this drug. I know I will never hear again, but I will at least go through and survive MDR-TB. There are around 480,000 MDR-TB cases estimated new last year. Unfortunately, we are doing great in detecting more, but it's like starting from very low place. So out of this 480,000, just 97,000 were placed on treatment. And out of this, and especially for the colleagues from I think you are from the European region, the treatment success is very low. So it's very sad the fact that you enroll people on treatment and globally just 1 in 2 will be cured. It's 48% the cure rate. And that global comes from the fact that in the European region is 1 in 3 and sometimes 1 in 4 that is getting cured. So after you go through all this horrible treatment, for many reasons, you are not getting cured. You can die or you can still remain positive. And there are many people that actually don't want to go through this treatment and they default. So the problem is not that we have this MDR there, is that, as I said, it's airborne. And each person who is not treated will infect between 10 and 15 others in a year. And it means that it doesn't stay in a corner somewhere there is the problem of those people. It becomes the problem of all of us. And we had a very heartbreaking story of a patient from Tajikistan last year for the World TB Day in Copenhagen, whose wife and 1 son died of MDR-TB. And he said he felt very guilty because he infected them, or that's what he thought. He got cured, and these 2 unhappy, unfortunate people died. And he put it very well. He said, I know how to protect, I know what behavior to have to protect myself against many diseases. I cannot stop breathing, so I cannot protect myself against TB. And that's what I think we always forget, is that TB is an airborne disease, and we are all at risk as far as we breathe. And I tell you that the moment you are in a car for a long time with a driver that coughed his brains out, and you go for 2-3 hours, you start thinking maybe it's TB, and maybe right now I'm getting infected with God knows what kind of form, and God knows how I will what will happen with me. So these are some of the maps with the incidents. I don't think it's a big secret in telling the high burden that we have in the Asian countries, in the African countries, as well as in Europe. You see, each of the region has their own specificity. That's why I don't believe too much in the global figures. I mean, in the global maps. African region has a huge burden. Just few lines that you need to remember. And it will not reach the MDGs for TB, and that's because of the TB-HIV co-infection, and that's because of the huge burden on the health systems to deal with TB. It's not well prepared. We don't know how much MDR-TB is there. It's a big challenge over there. European region is all about drug-resistant TB. The drugs were available. They were not necessary and well given to the patients, so a lot of a lot of TB is becoming and is replaced with MDR-TB in the European region. You will see if you will see from the figures that WHO put it last week that there are countries in Eastern European region in which 75% of the patients previously treated are drug-resistant TB, and half of new cases are drug-resistant TB. We can say that in that region, that normal TB is getting replaced with drug-resistant TB, and that's really scary. Asian countries are all about the private sector. It's all happening in the public sector, but in the public, but equally in the private sector. So it's a lot of private doctors and nurses, and around the corner cabinets happening in a lot in India, especially. That we don't know exactly what kind of care they are providing, what kind of drugs, what kind of treatment. So these are the main areas that there needs to be a big focus on in these regions. South America is a combination. There are no huge numbers in the Southern American region. There are some which are having a lot of MDR, which is Brazil and Peru, and there are issues related to the as well the engagement with the communities and the indigenous population in some of the groups in the Southern American countries. I think I spoke about MDR-TB. This is just illustrating to you the fact that you will get all these slides, but I'm not going to speak on all of them just because it will be good to have some interaction at the end. There are 27 so-called high MDR-TB countries, and you can see how it is spread. It looks like it's just 15% in Africa, but actually the labs need to be very well developed and equipped in order to diagnose MDR-TB, and we need to work much more in the African region in order to reach that. And you can see that, unfortunately, the European region is leading into this exercise with MDR-TB. This is just remembering us how many others are infected by each case, and I spoke about MDR-TB, but there is if the treatment for MDR-TB is not properly followed, and actually tonight we have a reception that I think is in Hotel Zero, Barcelona, here across the street, starting at 6 o'clock, where we have an ex-DRTB patient that, if she's still under treatment, that will present about that. Because ex-DRTB, the extreme drug resistance, extensive drug resistance, it's extreme in any way, is developed from very badly managing multi-drug resistant TB and creating it resistant to even more drugs. So it is estimated that 10% of all MDR-TB are ex-DRTB cases, which is, to be honest, and between us here, God forbid us if we get infected with ex-DRTB. It's a horrible treatment. It's very difficult to find it. We have everyday patients calling us and writing to us how they can find the drugs to make the cocktail for ex-DRTB. And to get through it, it becomes extremely complicated. The drama is that XDR, as MDR, and as TB is spread through air. And it is as well airborne, and is infecting as well 15 other people. So it's not that we have a change in the pattern when it becomes resistant. This is the African region in which, as you can see, the Southern African has a very high burden, as you can see, with incredible high rates. So this is the whining that you will hear a lot from us. It's the unhappiness of the figures that are telling us that we have a lot of work to do. And you will hear a lot in this meeting. We are very happy to work with the union, and we're supporting them in bringing at this meeting some high-level people. So we have the Minister of Health of South Africa, we have the Minister of Health of India coming, we have Michel Sidibe, we have Mark Daibo that are participating here. So I also invite you, if you want to join us Thursday morning, we have a special panel with all these people starting at 9:30 in, again, Hotel Zero, to discuss about how we can push the agenda in TB. And you will hear a lot about having innovation and thinking out of the box. So basically, you know, sitting there, you say, you know, these people, this woman came here, gave us the same presentation as she used last year, whining that there is a lot to do. What can be done? You know, if the numbers didn't change over years, it means that we need to try and do something different, because it's like if you try to do the same with the same tools that show it doesn't do any results, we need to change. And that's try to think in a different way and a bit out of the box. And it is possible. Here I just used few examples when people tried and thought out of the box. One is integrating TB and HIV services. The person which is HIV positive and has TB is one. It doesn't need to go in several places. You don't need to have a system for drugs for TB and HIV. You can have one. You make his life easier, you make the life of health worker easier, and you save money to your program. By doing, the countries that did that saved 1.5 million lives over 6 years just by integrating them. We have an initiative that is called TB Reach, together with our other platform called Global Drug Facility. So, you know, we give drugs, diagnostics, but as well we give funding for countries to make an effort to find the vulnerable groups. Basically, we allow NGOs, faith-based organizations to come and say, if you give me this amount of money, I can find these people with TB that are usually not the ones that are found, you know, the missing cases. So we, by working in some of the countries, we show that there can be a double detection and treatment if you work with the communities, and you can increase the 25 times the cases detected and treated just by looking where people are. You know, it's different if you have a little bit of money and you just spread it thin to everyone, or maybe just focus of those that are having less and, you know, will benefit much more from that investment. So that's where TB Reach tried to help in several countries and showing how it works. Okay, so I told you about the Stop TB partnership. I don't think that I want to go into, you know, the different people and teams that are working with us. As I said, we have a team that is giving drugs and diagnostics called Global Drug Facility. We have another team that is called, oh yeah, I thought it's me. I was like, oh, I started now. So this is GDF. The other one that I told you is the TB Reach that is looked over different type of innovative approaches. Mobile outreach, community, innovative transportation, different business model, different digital X-ray screening, just to give an idea that things can work. And when I say, just to give you an example, Lesotho came with a proposal to TB Reach to, when we read it first time, we were laughing because we thought it's a mistake. They were asking money to buy donkeys. And, it was the first ever that, we were based in the World Health Organization. You put a contract in which the money will be used to buy donkeys. But actually, Lesotho said, we have the labs pretty well equipped. People don't have access. to it. So I don't need you to give me more machines, more that, more that. I just need to get the sputum or the people to my labs. And that's what we did. So we bought the donkey, we gave the country the money and they bought the donkeys. And I can happily tell you that after that Global Fund continued to buy them whatever was the transportation, the different donkeys, and they have a type of horses, very solid ones that they were using as well, because that's what was needed for them to make a difference. And so this is about the, you see all of this is ultimately to try and find everyone that has TB and put the person on treatment and ultimately cure them. To do that, of course, you need money. Unfortunately, we all need money. And in TB, because we were not that much in the attention of the leaders and of the governments, the funding is never enough and there are huge gaps into it. The majority of the funding is coming, and it's not great, it's coming from the domestic resources because we also don't have many donors. So domestic and governments are putting money into TB as much as they can and in whatever they can, or it fits their budgets, and it's an entire story there. And we have as well funding from some donors. And from the donors, you can see here that the gap is 2 billion. Again, this is a slide of last year that fits exactly in the global TB report of this year. It's unbelievable. The same numbers. Nothing changed. These are the funding gaps. And these are the funding gaps per region. As I said, I'm not going to go into this. Obviously, the biggest gap is in the African countries, 50%, followed by the Asian. You will get the presentation. You will see. This is the, showed in exact numbers, not percentage. So you need 1 billion in the African region per year if you want to scale up and to have some hope of things getting changed. We are far away from getting that. That's the gap only. And this is to show that from our donors, we have the Global Fund, the major international donor. I don't know if you heard about Global Fund. The executive director of Global Fund will be here for our session Thursday. Global Fund was created to fund interventions on TB, HIV, and malaria globally. For TB is the air, because from all international resources TB is getting, 82% is from the Global Fund. So we are heavily dependent in the countries, especially in the African countries from that region. 82% of that comes from the Global Fund, which means that if Global Fund, for whatever reason, ignores or cannot cover some interventions, those programs are failing. If you can see here, HIV depends on Global Fund just 21% because there are other initiatives. There is PEPFAR, there are other groups that are looking at HIV and putting money into it. Malaria is 50%, and it's, so it gives them a bit of freedom in terms of addressing the gaps, and TB is, as I said, heavily depending on the Global Fund. This is, again, as I said, we fund a treatment action group, which is a group of activists and advocates in New York. Every year we fund them to do an R&D report, research and development report. So they look over who puts money into research and development for TB and other diseases. Again, nothing changed over last year. $600 million that come into TB, leaving a huge gap. Leaving even less is not only the gap, is the hope of getting a tool sooner rather than later. So this is the gap that remains, which is 1.4 billion figure. I know that some of you might be interested not only in writing about the health stuff. I know that we all need to see, and all the funding is coming from the ministers of finance. The ministers of finance will not put money without understanding if there is a business case behind it. What is the investment? What do I get out of it? Do I get something? Okay, people are healthier, but what else? So this is just making a case and showing the bad and horrible impact that TB has at the microeconomic level, in the families with children that leave the school once people get TB, decreasing the yearly income. And the fact that 75% of the people that get sick with TB are taking a loan to be able to get through it. That was for, I didn't know about this figure. When this study came out, I was really, really impressed about it. This is a study that was, this is looking more at the bigger picture, and the fact that, they made a study on what is the burden in the European region per year because of TB, and it's adding up at around 8 billion. When you accumulate what the burden and the cost is on the families, but also on the economies because of people not going or infecting others, and all the MDR TB aspects, as I said, which are a huge point in the European region. This is a slide that was not done by us, even though people thought it was done by the Stop TB Partnership, because we always try to make the case that TB is very good in terms of return on investments. This was put together in trying and looking for each dollar how much you get back if you invest. And it looks like if you put $1 on TB case finding and treatment, you can get 30 back. And it's the best case that you can do in comparison with HIV, or malaria, heart attacks, and others. This is my almost last slide, so I think I'm very much behind the time probably. You see, I think that's why I said that each of you can do something for it and can change it. Nothing can change unless we have some leaders pushing for it, and unless we have a bigger noise to speak about it. HIV/AIDS built a lot on the civil society and communities that were outraged every moment that there was not access to treatment. There is not enough funding for research to have a new diagnosis. Our communities were very shy. In TB, it was not a new disease. We were used to be very medicalized, pretty vertical, medical doctor, the nurse, and the patient somewhere there. We didn't have the communities outraged coming up when there were stockouts. People are usually pretty shy to speak about the TB. Tina Turner had tuberculosis. She's very scared even to be mentioned around her. Several personalities from my own country, Romania, had TB. I had to literally run after one of them physically to just have her stop and speak about TB, and they are just very reluctant to speak about it. India did a great thing last night. I don't know if you know that there was a 2-hour primetime show with a Bollywood star called Amir Khan that spoke just about TB for 2 hours in India, that generated 1.5 million phone calls as a follow-up of that. And it shows how much it can happen if we are reaching at that level. And that's why every single drop, every single thing you tweet and write about TB or Stop TB or our burden, it will matter a lot. I didn't focus and didn't speak too much about the role of the patients and communities. We will not go anywhere unless we change the approach in which we work with them. We are working on that. Communities and civil society and those affected should be at the table, not only when it's about do some work, but when you plan, when you do, and when also you monitor what is happening. And it's happening in some countries. We are piggybacking a lot on the HIV already existing networks. It's not happening in some. It depends a lot also on the culture and on the existence of networks. I come from Eastern Europe. We don't have volunteers. We don't have communities. It's very difficult everything is very medicalized, and very difficult to have a volunteer to come to give the drugs to a person which is not, is from another family or so. So there are different, but even that you can go around, and I think, if there is a will, things can happen. But what is the most important is really to challenge the way in which we are doing the work in TB and say, what can we do in a different way, and why we cannot integrate or do things in a much better approach. I'll just give you and I think with that one I'll finish. Okay, so this is how we can help, and this is the last slide, so I'll leave it there. I wanted just to give you an example about thinking out of the box and in a different way. I had an opportunity to be in Australia and to speak with the Australian government as donors in putting an intervention in Papua New Guinea just for HIV/AIDS, and reaching out with a huge amount of millions of dollars of the communities and religious leaders in the Papua New Guinea in order to educate about HIV/AIDS. And I said, once you have them in a room, you cannot speak just HIV/AIDS. You should speak about TB, you should speak about mother and child, you should speak about vaccination. You cannot miss that opportunity to do just HIV/AIDS. So it's thinking a bit different and challenging ourselves to do things in a different way. That was my last slide. I think we have time a bit for questions. I know that you come from many countries, and I didn't enter into any of the details of that because we can have time now into the conversation, but also because it would have been a bit too much to go over each of the countries. But I want to thank you very much for listening.
Lucica, can I just ask quickly at the beginning, I want all of you to have time for your questions. If I'm from India or China and I want to see the numbers for my country, where do I go? Where do I find them online?
Yeah. So there are two sources of information, but for the most reliable one is on the WHO webpage, where is the WHO external webpage where you go WHO in English, and then on that place you go and search for tuberculosis, and then you type in country profiles. Do we have internet here?
Yes.
So I can show you right away where it is, and it's producing the country profile and what is we will go over this. Now, that's one source. The other source is of course the Global Fund for the countries that China not, because China is not dependent on the Global Fund funding anymore. It graduated. But for all the India and I can tell you most of the countries that are getting Global Fund as well is entering into the let me say then Global Fund has also country profiles over there, so you can see how much money went into a grant and what happened with that grant, and what results are happening and how much money came, and sometimes it's striking. Malawi just this round will get 500 million from the Global Fund of dollars. So it's just to give you an example, it's a very useful information to get an understanding of that. Now, the WHO data that you will see are the data reported by the governments to WHO. And every single number there should be thought with a bit of umbrella because I worked in the reporting of the numbers to WHO in my own country. And the ministers who are signing on this data are always a bit worried on how they will appear on a global scale. There are some that could not care less, but there are some that are saying, well, do you think that's very bad? Yeah, well, why don't you take them for another week and come back with better figures? So then there is sometimes, and there is very often, a question mark over data because they are signed off by so many officials in WHO, in the country governments, that you never know if they really reflect the real reality or it's a bit cosmetized figure. But that's your role as a journalist, to dig and see, what you can find into, if it's the real figure or not. So any other questions in the meantime? I think I can handle. Okay, so go ahead.
I have two questions and one observation. The first question
Can you speak up so we can hear you in the back?
the first question is why are we having so many cases of drug-resistant TB? Is there something that is not going right? And then you mentioned deafness as being one of the side effects. Is this something new?
Mm-hmm.
And then one observation, I don't think it's the lack of money that is failing the TB fight. We had a case in Uganda where millions and millions of money from the Global Fund went missing because someone in the health ministry used the money for pocketed the money. So even when the money is there, it just goes missing like that. So that's just an observation.
Yeah. So your first question was on MDR. why do we have, and deafness, so first was why do we have so much NDR, then was on deafness, and then on the mind. So on why do we have NDR? So NDR is created when, so it's the normal bug becomes resistant to the TB drugs. And that is happening because the treatment that is given is not the right combination. The drugs that are given are of poor quality, so you think you take the right cocktail, but actually you take maybe just one drug or two out of 5 or 6. Patients are left on their own and take just one drug out of the how many they have. I was a clinician in Romania, and I had a patient which I really thought he's following the treatment, so I was very relaxed. And after 2 weeks, he was still not well. And then I started questioning what's going on. And what he was doing his own way of dealing with the drugs. He was taking the white ones a week and the red ones the next week. So for a week, he just took the white pills. And the next week, he took just the red ones, ignoring the white ones, telling to the nurse that everything is fine. And because he was an educated gentleman, the nurse believed him. So he didn't say, can I see you swallowing? You feel sometimes embarrassed, you look and you. So patients are left alone, and for whatever reason they decide to take or not to take the treatments and so on. So that's the third reason, and the fourth is that sometimes there are not enough drugs. So doctors start the treatment. The treatment is 6 months. The rule we say is that you better don't start if you don't have the 6 months treatment available. So it's very bad, but don't start because you create resistance. They take 2 months, and then something is not available anymore. So that's how you create the resistance. And in a way, in countries that had limited access to the anti-TB drugs, you see less resistance because drugs are not there and people didn't start. That's why in Eastern Europe, where some drugs were available at some times, they were happening, you will see an increase in the number of cases. So that's on the first. So when you have MDR-TB, you take other drugs than if you take in the normal way, and you take treatment for 2 years, and you have an injectable for 6 to 8 months, and you make an injection 6 to 8 months, and then you have a cocktail that gives you a lot of side effects. And I tell you, I have a friend of mine who is a clinician that is now going through this treatment in Romania, and she knows, it's like I get sick. And she still feels the need to interrupt the treatment because it's giving you huge nausea, huge. You vomit your brain out. It gives you a lot of psychiatric effect. Like you are very depressed. You try to kill yourself. You are getting hugely closed in yourself, and you have a lot of bad thoughts. And for some, another side effect is deafness. So that's the drama. It's not that you have a 2 years treatment, costs like hell. Half of people might not get ever cured after all this mess, but also it gives you a huge second. I agree with you on the money, and I didn't know you come from Uganda, but if attention is there, or if people speak about it, funding probably will be found. We organized a meeting with some countries, and we said we have no money to have you come. But then once the Minister of Health understood the importance, money were available for everyone. It's not that it was not there. But I think the noise level at the country is not there to make everyone think and say, oh my God, I really need to take care of the TB problem. So just to show you, I went into this, and you can copy. So you say I went there, I went into the TB part, I went into country, I wrote down data profiles, and in English. And you put here a country, so let's choose for fun my own country, that nobody will say she chose whatever. So here is Romania. And then you can do different things. So you will have here, if everything goes fine, and I hope it goes, you will have generated, this is the Romanian profile for 2013 with all the data. And you can see the trends, and you can play with it, and you can see how many, you might need a bit of help to understand each of the things here, but it's not that complicated. So, you can see that, there are some good things happening in terms of going down, but I tell you that the rhythm of going down in Romania is also not giving us too much hope. You see that there are, different moments of, there is this graph here which speaks about the treatment success rates that you see that was not recorded from the beginning. So that's why you have these scattered points all over the place. And this is the budget. And in reading the budget, especially in the WHO report, I recommend cautious, because again, it's coming from the government, and the government will never say what is missing for civil society. Actually, they would not care less. What is missing for vulnerable groups, for drug users, for sex, so here is very much public health perspective, unless you have a really smart TB program manager that will report the figures in a different way. And then you can go and do, I think there is a possibility, if the country reported, to do something on the, and look just on the financing piece. If you scroll down, yeah, so let's see, I don't know if Romania did anything, so I will go to Cameroon maybe, I don't know. Let's see if the financing is here. So then you can also have, yeah, Cameroon provided some figures in terms of the funding. So you again, you can play with each of your country and get all this information in detail. You can also, once you do that, if you have difficulties in understanding what's underneath this, feel free. My email is in the presentation, and even if I don't have time, somebody from my team will come back and explain if you say, well, I don't get what this is missing or not. The other one is the Global Fund. And that's important because it speaks, I rely much more in terms of money on the Global Fund, because, they give money and they need to have their numbers in order. So then you can also compare some of the figures there, and, if you want to make a comprehensive analysis, if you want to make a comprehensive analysis about a country, then you can, you see here again we have, I don't know, let's say Azerbaijan. And then Azerbaijan, you see here, these are the key results obtained with Global Fund money. They have a very good web page, and you can see here how many grants are in the countries, and there are 3, 2 for TB, 1 for HIV/AIDS. And then here is how much money were already signed, so you have the total amount. You see for TB, there were $42 million and This was signed. This was the Global Fund said will give. How much they disbursed out of this is just $76 million out of what I think is like, 190. So they still have a lot of money to disburse there. And then you can look over the list of the grants, you see. And then you go here, you have tuberculosis, and and then you can open that one and see what they were doing with that money. So you can go for your own country and find some interesting stuff over it, because you see what was obtained, So I think this, if you want to go and say, okay, I want to write about TB in Uganda, you will get information from WHO, you can get some from the Global Fund, and you can make a good picture of it. There was another question.
Why MDR TB can affect 10 people, but the normal TB can affect 15 people?
No, it's between 10 and 15 for both. There is no difference.
No difference.
No difference between both of them. So I don't know if the slides were saying 10 to 15. The slide should say 10 to 15. So it's no difference between MDR TB, normal TB, and XDR TB, and how many can be infected.
Okay.
Dr. Ditiu, as there is so much scarcity of funds, do you still think that India should be given, I am from India, but I want to ask this question. Do you think still India needs to be given this global fund?
That's a very good question. You can ask your niece. If you ask me, India sent something on the Mars, right? And many others. So I think, you see, this is a conversation beyond India. It's a conversation that was also because sometimes it was also about China, and it's coming as well in Europe. It's about graduating countries when they start becoming so wealthy that they can take care of their own people. When is that moment? And the reality is that sometimes if you have a smart donor that is investing in a smart way, it can leave the government to invest in things that is easy for the government and pressure interventions that otherwise will never happen. So I'm speaking here that if you really want to address community issues in a country, sometimes you need a donor like the Global Fund to pressure that, because it might never happen from the normal budget. It's not that it should maintain forever, but it might be good to say, well, government can easily pay the salaries, the first line drugs, the second line drugs, hospitalization, but the extra effort and investments that needs to happen for vulnerable group, for drug users, might be easier if it's happening with the funding of a donor. The answer specifically for India is no, but there are conversations in that. This new minister seems to give hope. I will not make a secret that all of us were hanging on the Southern African minister, because he came and said, I can be the chair of your partnership because I want to support you. But also he has what I call in Romania balls. I mean, the guy is like, why should people die of TB and HIV? And actually he walked to the talk in South Africa. He really said, is the problem with the contacts? Let's find the patient and his contacts. So he sent teams of people in 400,000 households to find all the contact info. So we had hope there. I understand that the new Indian minister is very strong. He also said, I need bigger targets and bigger actions in India as well in terms of TB. And there is a conversation pending between him and Mark Dalbo that will actually, we offer them a room and an opportunity to do that while here, exactly on this topic, because I think as 2016, probably India will not anymore receive money from Global Fund, but don't quote me because it's not my decision. It's between themselves, yeah.
Okay. Is there one more question before we let Lucica go? Right at the end of our time, but
Yeah, I just wanted to find out what is the TB community doing to ensure continuity in programs, especially in African countries, which are high burden, but also benefiting from the Global Fund, considering that the Global Fund is now encouraging domestic funding.
Yeah. So what we try to do is you see, I spoke with the president of Kenya and made the case for domestic investments in TB, and he said, you convinced me. I don't need anything more. I'll just focus on TB, he said. But you know what is your problem is Michel C. Dibe from UNAIDS speaks equally passionate about HIV/AIDS, and I will have next week when he's coming, I will have to promise him the same. So we discussed, and you know, the approach that we want to take is to ensure that we have a coordinated voice in speaking about domestic financing, especially in the African countries where HIV/AIDS and TB are going hand in hand, rather than going piecemeal, and trying to push that investments are addressing both of them and not a separate one. So one of the things is we work with the African Union together with UNAIDS in making sure that when they discuss about the pledges that they made and the percentage of the domestic funding that will go into TB, HIV, and malaria, the famous 15% is reached out. So we try to measure, is that happening or not, from the Stop TB partnership. And also we tried to support the African Union in analyzing how far or close different countries are on this. The reality is that you need to see also donors putting their heads together in addressing it in the same way, and you know, saying we are phasing out, you know, how sustainable is what we put it in place, and how can we look at it into a comprehensive manner, and not going again, you know, like this is malaria, this is HIV, this is mother and child, here is UNICEF, here is UNAIDS, here is WHO, here is Stop TB. So we are addressing it. I cannot say that it's huge, how to say, we don't see the huge movement into it. There are some that are happening. So we had a Zambian case 2 weeks ago in which we showed that the new data for TB are showing an increase in the number of cases, and it cannot be covered with the Global Fund, who was unprepared for that. We don't have money to tackle that much Zambia, so the government placed 3 million from their own budget suddenly, which shows that the money are there to cover that piece. So it's a long way to go. We need a lot of help, because you see, all of these requests targeted high-level political advocacy efforts, and for that you need people that are able to do that. And we don't have very many in TB, nor the needed funding to do it in a proper way. But we piggyback with the others a lot.
Thank you. Dr. Ditiu.
Good, thank you.